Good morning and welcome everybody to this session on pulmonary hypertension. Pulmonary hypertension represents a clinical challenge to the practicing anesthesiologist because it places patients presenting for surgery in a high-risk category. This risk, coupled with relatively limited therapeutic options for pulmonary hypertension, complicates the perioperative care. This chapter outlines the pathophysiology of pulmonary hypertension and anesthetic considerations when caring for these patients. Definitions and etiology. Pulmonary hypertension is defined as a syndrome with elevated pulmonary artery pressures. The mean pulmonary artery pressure more than 25 millimeter mercury at rest. This is associated with reduced nitric oxide and prostacyclin synthesis as well as with increased thromboxane production. Histologic features include medial thickening and intimal fibrosis. Classically, this was described as primary or secondary pulmonary hypertension. In 1998, the WHO, World Health Organization, adopted a new classification system describing the 5 categories of PH. 1. The isolated pulmonary arterial hypertension. This includes primary hypertension, pulmonary hypertension, systemic to pulmonary shunts, and collagen vascular disease. Pulmonary arterial hypertension is defined as exclusion of secondary causes, elevated mean pressure more than 25 millimeter mercury, and elevated pulmonary vascular resistance of more than 3 Woods units. Pulmonary arterial hypertension is associated with disease of the respiratory system and/or hypoxia. Includes the chronic obstructive pulmonary disease, obstructive sleep apnea. Pulmonary venous hypertension includes the mitral valve disease, chronic left ventricular dysfunction. Pulmonary hypertension is associated with chronic embolic or thrombotic disease, or pulmonary hypertension attributed to direct obstruction of the pulmonary vasculature by inflammatory pulmonary capillary hemangiomatosis. Pathophysiology. Acute changes. The normal pulmonary vascular resistance is less than 90% of the systemic vascular resistance. Because the right ventricle is designed for a low pressure system, an acute increase in the pulmonary pressure often results in rapid right ventricular failure, that is acute pulmonary embolus or acute severe mitral regurgitation. Chronic pulmonary hypertension. This tends to develop over time, allowing the right ventricle to compensate for the increased work via the hypertrophic changes. Unfortunately, the right ventricle has limited ability to compensate in this manner and will eventually dilate and fail. Right ventricular failure leads to a variety of events. Reduced right ventricular stroke volume, decreased preload to the blood ventricle, and resultant hypotension. Intraventricular septum of the dilated right ventricle shifts towards the left ventricle, further decreasing the left ventricular output. Reduced right ventricle coronary blood flow secondary to disruption of the normal systolic and diastolic coronary blood flow pattern. Right to left shunt may develop in patients with a patent foramen oval, more or less 30% of adults, resulting in hypoxia. Surgical and anesthetic risk. These patients are at high risk surgical candidates. Published series demonstrate a range of surgical mortalities from a low of 4% to a high of 24%, depending on the disease severity and surgical procedure. Surgical and anesthetic risk should be clearly stated to the patient, especially for an elective case. Hemodynamic spiral. Acute deterioration is possible as right ventricular failure causes reduced pulmonary blood flow, leading to hypoxia, which subsequently increases the PVR, that is pulmonary vascular resistance. The elevated PVR ultimately leads to increased strain on the right ventricle. This initiates a catastrophic hemodynamic chain of events where the decreased right ventricular stroke volume decreases left ventricular output and coronary blood flow decreases to both the left ventricle and right ventricle. The already failing right ventricle may not be able to recover from this, resulting in cardiac arrest. The death spiral is always potential in pulmonary hypertension patients. The anesthesia provider should be aware of it and take steps to prevent it. Now we come to the end of this part of the lecture series. I will come with the remaining in the next series. Thank you.